Ruxolitinib is an inhibitor of both JAK1 and JAK2. It's downstream of the IL-6 receptor, IL-1 beta, and IL-23 receptor, and it's required for induction of Th17 cells that are important for the pathogenesis of both acute and mostly chronic GVHD. Work in the Perseus lab has shown that JAK1 is important in the GVHD pathogenesis, and work in Dr. Bat's lab have actually shown that JAK2 is important in the pathogenesis of GVHD. Therefore, it is possible that single JAK1 or single JAK2 inhibitors may be able to prevent GVHD or treat GVHD with less toxicity. Single inhibitors will be developed, but they are all at an early stage at this point. Since JAK1 and JAK2 are downstream of IL-6 receptor, it is rational to block that receptor for GVHD prevention. Work by Hill and others from Brisbane have actually supported that concept, and a randomized trials has been completed. The data from that trial is outstanding and is expected later on this year. There are other agents that are of interest in the prevention and treatment of GVHD, such as sirolimus, which is an mTOR inhibitor, and bortezomib. Each of these two classes of agents has been tested in individual settings, but right now the exact use in the management of GVHD, prevention or treatment, acute or chronic, has not yet been defined. A number of other agents are in development for the management of acute GVHD, including alpha-1 and antitrypsin. This is a very safe agent. The question really is whether it's going to show efficacy in appropriately conducted clinical trials.